So starting with the first question, that is, I think the CF classification or the type stage of the condition was asked as per the CF classification. I think the image was of lipodermatosclerosis as given here. And as per the CF classification, the lipodermatosclerosis is C4B. So I think the answer here is C4B. I think no doubt about this. I hope the question stem and the options are okay. Any discrepancy or any changes, please let me know right now. Any issues or discrepancy in this question? Right. Moving on to the next question. That is about a patient who is undergoing LAR or APR. What was the surgery exactly? I think it was a lap APR. That is what some of you have told me. Was it LAR or APR? And the lymph nodes were present along the length of the IMA. So where is the IMA ligated? Can you help me out with the question stem? APR. Okay. Lap APR. And the lymph nodes were present along the length of the IMA. Was that the question? So if lymph nodes are present along the IMA, you cannot do a low ligation. You have to go for a high ligation, and that high ligation is near the flush at the origin of the IMA. Basically, that is, you do as high as possible. So herein you have the correct answer as flush ligation. You do not do after the origin of first branch. That is usually the left colic. You only do that. That is basically a low ligation. That is you do after the first branch is out. That is the left colic. If you do it before that, that is just at the origin from the aorta. That is high ligation, and that is what should be done in the case here, wherein there are lymph nodes are present along the IMA. So here the answer is flush ligation of the IMA at its origin. This is a very simple concept, and that is also what we routinely follow in our clinical practice. So here there is no discrepancy in this. The answer would be flush ligation of IMA at its origin. Lymph nodes where present IMA wasn't mentioned. Please clarify about the question. But if it is a lymph node positive disease and they have given it along the IMA, or they have asked, usually the high ligation would be better answer according to me. Was lymph nodes along the IMA given? What was the question stem? Please let me know. Yeah, if it was along the IMN, there is no doubt about this. The answer would be flush ligation, that is high ligation should be done. Now, what about this question? The image was this, that is for the Charles procedure image was given. And what is true was asked or what is false was asked, because there is two discrepancy in the recall given by you, that some of you mentioned that true was asked, some of you mentioned that what amongst the following is false is asked. Can you let me know true was asked? Okay, so identify the true statement. So this is directly taken from Sabiston, and the paragraph they have clearly mentioned all the statements what they have mentioned. That includes complete and circumferential excision of the skin and subcutaneous tissue and the deep fascia of the involved leg and dorsum. So A is not correct. Okay. If you read from the textbook, it is basically complete and circumferential excision of skin, subacute deep fascia of the involved leg and the dorsum of foot. They have not mentioned deep fascia. I think that is what you guys have given me the recall. Deep fascia is not mentioned. So they have taken this from the textbook. So they have taken the lines also from this. So here A is incorrect. It is basically done in advanced cases when the skin damage and infection is there. So it is basically all the surgical treatments are done when there is the damage and there is infection and the skin damage is there. And usually it is performed, excision is performed in one stage and coverage is done by STG. So I think it is not a staged procedure. So even that is not correct. So the best answer is done in advanced cases when there is skin damage and infection. Can you help me out with the fourth option for this question, please? What was the fourth option so that we have a proper recall? Graph take is approximately 58%. Yeah, see, there is Charles procedure is basically skin, subcu, and the deep fascia. They've only mentioned about skin and subcu in the option. I think that is what you have given me the recall. So deep fascia of the involved leg is not mentioned, so that cannot be the answer because they have asked about which is true. So it is done in advanced cases and in skin damage. And if you see the percentage also change, the skin graft take was 88%. Here they have mentioned 58%. So that is clear that they have taken it from Savaston textbook and from this particular paragraph. So there is no doubt about this. Then the answer is B in this question. Next, about a chronically bedridden patient for the past 3 months having pressure sore overgluteal region. And according to all of you, the pressure sore, what was mentioned, was either grade 3 or 4. In grade 1 and 2, there is no doubt about anything else, but in grade 3 and 4, this has been confirmed with the plastic surgeon, Dr. Neil, who is a plastic surgery faculty, that in clinical practice, whenever they have a bed sore, whenever they're planning a flap, albumin has no role in that. What you go is you do a MRI. Why MRI is done? MRI is done to basically evaluate the soft tissue and also the bone specifically to rule out osteomyelitis or anything. Why? Because you have to remove the part of the bone as well along with the flap coverage so that there is no recurrence of the pressure. So the answer here is MRI for this bed sore case, and this has been confirmed by a plastic surgery faculty, so there is no doubt or discussion about it. You albumin has no role in this. Okay. Hope the options are okay. PTINR, albumin, electrolytes, MRI. Is there any discrepancy in this? Please let me know. Yeah, okay. Moving on to next, massive hemoptysis is not seen. Yeah, MRI or MRI pelvis, anything is fine. MRI is the answer here. MRI was given, MRI is the answer. So massive hemoptysis, see, it is not related to the wound as such, because once wound is healthy, then only you will plan for a flap, because so that you have adequate coverage. But the MRI is basically to rule out the osteomyelitis and also the evaluation of the bone and the soft tissue, so that when they go in for surgery, they may and they will remove the bone as well to make sure that there is no recurrence, and then only they will give a flap coverage, because otherwise, if there is the bony involvement with you do a flap, it will fail or it will be recurrence. So that's why MRI is necessary. So next question about massive hemoptysis is not seen in. So this is again classically taken directly from Schwartz. This table of massive hemoptysis given in the Schwartz, wherein they have clearly mentioned extrapulmonary as metal stenosis, bronchiectasis, tuberculosis. MR is not a cause of massive hemoptysis. I think this question and the options are also okay. No issues in this. Any discrepancy in the options? Yeah. See, nutritional status, prealbumin can help you in checking for the nutrition status, but when you are going to do a pedicle flap, usually nutrition status is of not that much important. And in clinical practice, also, that is not of that much importance. As much importance is there for the MRI, and hence MRI is the answer. Massive hemoptysis not seen in MR. Moving on to the next question, that is a female patient with high risk or a moribund patient with irreducible or a complete like non-reducible rectal prolapse. What is the management? I think third string, less like obsolete procedure, open surgery, not done for any rectopexies. You go for either lap rectopexy, or if there is a prolapse procedentia, you go for Alzheimer's proctosigmoidectomy. So that is the correct answer here for this question as well in high risk female patient. And even if you see, the perineal procedure of Alzheimer's are preferred in elderly or comorbid patients. So I think that is the correct answer here. Yeah, open surgery or the abdominal approach. Yeah. Okay. So that was the fourth option. So no discrepancy in this question as well. Okay. So next, male patient with jaundice with painless palpable gallbladder. This is the classical Courvoisier's law. So here the straightforward answer is CA head of pancreas. CAGB does not have a palpable gallbladder. Meresis usually does not have. And choledocholitis is also they never present. It is a classical Courvoisier's law, and the answer is CA head of pancreas. So here again, this is a very straightforward question. I hope the question stem and the options are okay. There is no discrepancy in this. If anything, please let me know so that I can immediately get it sorted here. Right. Yeah. Move on to the next thing, that is in which condition is BiPAP preferred over CPAP for management. I think the question stem is okay and the options are also okay in this. Yeah. So here, even if you don't know or not, you have not gone through that topic, you will see by ruling out that pulmonary embolism, there is no role or confusion between BiPAP or CPAP. If the patient is unstable, you intubated. Refractory ARDS, you will require the invasive ventilation, not non-invasive. Now there is a confusion between hypercarbic and hypocarbic. So whenever there will be CO2 retention, you will put the patient on the BiPAP, as you have seen in the obese patients. And this is again taken from Sapiston, when they have picked up the line where there is mentioned that this machines of BiPAP are well suited to provide supporting care over CPAP in cases of hypercarbic ventilatory insufficiency. So here the correct answer is hypercarbic ventilatory insufficiency. This is again taken from Sebastian portion of the critical care chapter. So if you see Schwartz, Sebastian, all the chapters from the first to last, somewhat another, they have taken something another thing. So now it is no longer, since last 2 3 years I've been saying that there is no particular important topic in NEET SS. So please, those who will be preparing for next year, please be aware about this. Next, a female patient with low hemoglobin scheduled for having blood transfusion. Within 15 minutes of transfusion, she has fever, tachycardia. Transfusion of stopped. Investigations were said. Urine analysis showed hemoglobinuria. Which test will show you acute hemolytic reaction after BT? Is this the correct question stem? Any changes in this and the options? And help me out with the fourth option as well. Can you help me out with the fourth option? Peripheral blood smear, Coombs test, clot retrieval test, and bilirubin elastometry, bilirubin. Okay. Right. So here again, they have went on to the SWOT chapter where they have clearly mentioned about the investigation and the symptomatology of the hemolytic reactions, wherein you go for the Coombs test for the lab investigation, and you have hemoglobinuria and hemoglobinuria. Best test to identify hemolytic transfusion reaction. Yeah, okay. Best test to identify hemolytic transfusion reaction or transfusion reaction for that matter. The correct answer is Coombs test. Okay, again confirmed from Schwartz, which we have clearly summarized here. Now, a defect to the right of the umbilicus in a newborn with the bowel exposed or clubbed or matted. I think that is something what you guys have said in the recall. So the correct answer is gastroenteritis, and the key is the right to the umbilicus. That is full thickness abdominal wall defect to the right of umbilicus with matted bowel. Okay, so to the right of the umbilicus in a newborn, it cannot be omphalocele. It is only gastroenteritis. What were the other two options? Please help me out with that. Umbilical hernia, and what was the fourth option? Please mention in the chat box. What was the fourth option? Anything? Gastroenteritis, omphalocele, umbilical hernia, and Spigelian. What was the option, please? Patent vitalointestinal duct. Okay. Okay. Yeah, the correct answer is gastroenteritis. So moving on to the next question, that is about a patient with 3.5 centimeter renal mass, asymptomatic confirmed within the renal capsule. T1A renal tumor was given. Most appropriate management. Any discrepancy in the question stem and the options here in this particular question? CT image, solid renal mass. Okay. Okay, so for a less than 4 centimeter renal tumor, it is very nicely mentioned here that you go for a nephron sparing surgery or a partial nephrectomy in tumors less than 4 centimeter, which is the gold standard. And for the selected tumors, only you go for above 4 centimeter. But as the size mentioned here is 3.5 centimeter, the correct answer is partial nephrectomy. This is again from Bailey. So next question, after MI, patient with chest pain has hypertension, pansystolic murmur, what is the cause? So can you help me out with the fourth option and any issue in the question stem and the options? Please let me know. Okay, lost electromechanical dissociation. Okay, after 3 days. Okay, so after MI third day, patient has chest pain, hypertension. Okay, electromechanical dissociation was given in the question stem, was it? So after third day, patient retrosternal back pain was there, sudden hypotension and a pansystolic murmur. Was this question there? Chest pain, hypertension. Okay, so chest pain, hypertension, pansystolic murmur after 3 days of MI. So what is the cause? It is a ventricular septal rupture. Again, it was taken directly from Bailey. That ventricular septal rupture typically presents 3 to 7 days after infarction with pulmonary edema, pansystolic murmur, hemodynamic instability. So they have taken from this paragraph of Bailey. So again, Bailey is also very important. So here the answer is ventricular septal rupture. So electromechanical dissociation, was it in a different question or it was in the same question? Please let me know. Okay. with electromechanical dissociation. I think in the recall there is another question of cardiac tamponade. I think that was the case. So herewith we'll just try and keep that it is with electromechanical dissociation. But as per the scenario given after third day with hypotension and pansystolic murmur post MI, the correct answer is ventricular septal rupture. There is no other doubt because they have taken directly from a line. And remember that if a clinical scenario is given with no specific mention about a particular line from the textbook, then the answer can vary. But if the question is taken from a particular line, then the answer will be according to the textbook, no matter how it is in the scenario and the differential. Okay, with retrosternal pain and one with electromechanical dissociation. But for this particular with MI on the third day and with hypotension and pansystolic murmur, the answer is ventricular septal rupture. I think once I come to the another question which you guys are telling, that I'll again discuss and sort out the issue between the two. Next question, dysphagia, tolerating liquid diet, CT scan showing tumor from 30 centimeters from incisor, 4 centimeter length, 18 thickness, circumferential growth, adeno-CA with mediastinal subcarinal lymph nodes with abutment with the aorta with no metastasis, what to do? Was Is this scenario exactly how it is or any change in this? And are the options okay? 75-year-old patient. Was pericardial involvement given in this esophageal question? Can you let me know what were the four options again? One was definitive CRT. Another one I think was neoadjuvant CRT followed by surgery. Stenting and palliation were in the same options. Pericardial involvement as well. Okay. McEwen's followed by chemo. Okay. Followed by adjuvant therapy. And lastly, stenting and palliation. Okay. Where this is the four options. That is definitive CRT, neoadjuvant CRT, surgery followed by adjuvant and stenting or palliation. Where now the options are okay. Okay. So, as per the given scenario, that is abutment with the aorta, pericardial involvement was there in the question. Yeah, and the 75-year-old patient also, followed by reassessment. Okay. Neoadjuvant followed by reassessment was there, or and surgery was there. Okay. Neoadjuvant followed by surgery was there. So here the correct answer would be a definitive CRT, not a neoadjuvant CRT. If pericardial involvement is also there and a old age patient that is 75-year-old, then usually it would be a definitive CRT, but reassessment for surgery after neoadjuvant. Okay, yeah, abetting pericardium was also there. Yeah, so now the options are okay, right? Definitive CRT, neoadjuvant followed by CRT, McEwen's followed by adjuvant, and stenting and palliation. Was involvement or abutment given? I think there is a lot of confusion in the recall. Okay, so again, abutment with aorta and pericardium. See, abutment. Yeah, so if abutment, if it was given with the aorta 90-degree with mediastinal subcarinal lymph nodes, then I'll again point towards the question of neoadjuvant CRT followed by reassessment or followed by surgery, but followed by reassessment obviously before surgery. I think there is a very particular terminology of abutment and involvement. So if involvement was not given, if abutment was given, then it would be a neoadjuvant followed by reassessment or surgery, whatever is the question, because there is a biased recall. Some are telling abutment, some are telling involvement, some are telling surgery, some are telling reassessment. But very clearly, if involvement, it is a inoperable or a locally advanced, basically you go for the neoadjuvant chemo radiation therapy, reassess. If it is not resectable after that, you go for definitive. If it is resectable, you go for surgery. So let's revisit again this question. I think many of you are telling different things. So according to me, as I had said, that for any esophageal cancer, if there is given mention as abutment with these structures, it is locally advanced. And in that, you go for the chemoradiation therapy, you reassess. And basically, if this converts into surgery, then this chemo radiation becomes neoadjuvant. If after reassessment you cannot operate, you have to continue with that, it becomes definitive. But in this question, as per the given scenario with abutment mentioned, I would still go for neoadjuvant followed by reassessment if that was the option. If neoadjuvant followed by surgery was the option, then I would err on the favor of definitive CRT. So see, if it is inoperable, it is definitive CTRT will be better. But see, stenting and palliation in the same sitting is not the correct answer according to me, because patient is tolerating liquid diet, and sometimes what happens is that you go for neoadjuvant, you reassess, sometimes the patients get better and they start tolerating the diet, because stenting has its own morbidity and complications. So usually if the patients are able to tolerate even little bit of liquids as well, they are put on liquid diet, they are given neoadjuvant therapy, and then they are reassessed, and then sometimes it is decreased and the tumor shrinks and the patient gets better. So and then you can plan for surgery. If the tumor has shrunken, it has become resectable. So in this, according to me, neoadjuvant followed by reassessment would be the answer here. Okay, so moving on to the next question. A patient with anterior mediastinal mass with X-ray showing elevated left hemidiaphragm, CT showing pericardial involvement, and phrenic nerve involvement, left eventration. Basically, what is appropriate management in this case? So if fat plane was not mentioned, if it was involved, basically it usually becomes a type of a definitive, but it all depends on the patient habitus and everything. But as per the given scenario, the answer, best answer according to me, would be neoadjuvant followed by reassessment followed by surgery. So here, please help me out if the correct question and the options are mentioned. Anterior abdominal, anterior mediastinal mass, left hemidiaphragm elevated, pericardial involvement, phrenic nerve involvement, left eventration of diaphragm. And the options are do radical surgery with en bloc resection with involved pericardium, compromised phrenic nerve, CT guided FNAC. You have the enterolateral thoracotomy or median sternotomy with a generous biopsy and a median sternotomy. Uh, Median sternotomy and biopsy was the option. Okay. Is the question stem okay? And the all the four options are okay? Yeah, so the correct answer according to me would be CT guided FNAC. So if you see I've gone and what was the age given? So young male or a young patient. And according to me, as per my research in the articles, and I've gone through in the Schwartz as well, and what I've seen is that in the mediastinal tumors, if you are able to do a CT guided biopsy or a CT guided FNAC, that is usually how you should do it, because the biopsy for a mediastinal mass is by opening, doing a surgical biopsy, which is had any which has its own set of morbidity associated. So how can you do a full resection when there is involvement of the pericardium and the phrenic nerve as well? Because there is also left eventration, that is because of the phrenic nerve involvement. So you cannot directly go in, jump in, and go for a tumor resection. It does not mean that any anterior mediastinal mass means that you go and do operate the case. I have gone through the Schwartz portion, I've gone through the articles, and all the articles mentioned that whenever there is a mediastinal mass, when there is a diagnostic challenge, you need to understand the exact nature of the specimen or exact nature of the tumor. You cannot correlate between chest wall involvement and involvement of the pericardium and involvement of the phrenic nerve. And here they have not mentioned anything about the tissue diagnosis, whether it is a thymoma, neurogenic tumor, or what exactly are you dealing with. It is an anterior mediastinal mass with CT showing involvement of the pericardium and phrenic nerve. So here, according to me and according to what I have gone through Schwartz and the various articles for mediastinal mass, the histopathological and the immunohistochemical diagnosis is important. CT-FNSC, CT core biopsy is what is required first. If that is not giving you any idea, then you go for a surgical biopsy. That is the best kind of biopsy. But yeah, pericardium can be removed. I understand, true. But here the important thing is about the phrenic nerve involvement with left eventration. So you cannot, if this patient comes to any cardiothoracic surgeon, they will not directly go in and do a thoracotomy or a median sternotomy, telling the patient that let me go and open up your chest and see if I can remove the tumor. If not, I'll just take a biopsy and come out. It is not like going in for a diagnostic lab. It is a very morbid procedure. So just go and read for the mediastinal mass in the thoracic chapter of Schwartz. You will see that first they mention about non-surgical biopsy, then comes surgical biopsy, and CT FNAC with core biopsy has more sensitivity combined together. But here, for the given scenario, according to me, the best answer would be a CT guided FNA. Okay. So in the clinical scenarios, you have to sometimes also evaluate the clinical scenario. You cannot just jump in for a surgical biopsy, specifically when it is a laparotomy or a median sternotomy or an anterolateral thoracotomy for that matter. So here the 14 questions what I've discussed for all the late joinees. So the given image of lipodermatosclerosis, CF classification 4B. Lap APR with lymph nodes along the IMA, flush ligation of IMA, that is the high ligation should be done. Charles procedure, the true statement is done in advanced cases when the skin damage and infection is there. Chronically bedridden grade 3, 4 bed sore planned for flap reconstruction. Preoperatively, most important for this case would be an MRI, not albumin. Massive hemoptysis is not seen in MR. That's the answer here. 75-year-old female with rectal prolapse or procedentia. Answer is Alzheimer's rectosigmoidectomy. Then you have painless jaundice with palpable gallbladder, classical Courvoisier's law, diagnosis C head of pancreas, BAPAP preferred over CPAP in hypercarbic ventilatory insufficiency, hemolytic transfusion reaction. Best test will be Coombs test. Right of umbilicus in a newborn or infant with bowel exposed or matted, that is gastroschisis. 3.5 centimeter solid renal mass. I think CT image was given, but asymptomatic, confined to the renal capsule. Best treatment is partial nephrectomy. MI post 3 days with chest pain, hypertension, pansystolic murmur, classically from Bailey ventricular septal rupture. Locally advanced esophageal tumor with abutment with the aorta, pericardium, and lymphadenopathy. So in this, neoadjuvant reassessment followed by surgery is the best answer. Intermediate renal mass, locally advanced, I think, with pericardial and phrenic involvement. Appropriate management first would be CT guided FNAC to get a histopathological examination done. So, roughly, I have covered 66 questions till now, including this session. So, thank you all for the subsequent questions. Please let me know. See, this is directly taken from Sebastian or the Bailey of lipodermatosclerosis. So that is the correct answer, C4B. So for the subsequent questions, please let me know for any recall if you have. Please send me across so that I can take the other sessions as soon as possible. Thank you all for joining.